Hello, thank you for joining me. My name is Anna Lander, and I am going to present my proposed change on incorporating more concentrated social need assessment in patient care. Just to give a little insight of why I chose this change, we must first understand what is mental illness. As defined by Dr. Parikh with the American Psychiatric Association, mental illness is defined as a health condition that involves change in emotion, thinking, or behavior, or a combination of these. Mental illness is associated with distress and/or problems functioning in social, work, or family activities. Mental health involves effective functioning in daily activities, resulting in productive activities like in work, school, caregiving, etc. Healthy relationships, and the ability to adapt to change and cope with adversity. Mental illness takes different forms. Some are mild and only interfere in limited ways with daily life, such as phobias. Other mental health conditions are so severe that the person may need care in a hospital. With this being said, I feel like it is safe to say that mental illness can look different in everyone. And if any plan were to be individualized, it would be a mental health plan. In order for a plan to be individualized, the patient needs to be thoroughly assessed for what they believe is the problem. It's their plan. They're the ones who would have to follow it. It is more likely for an individualized plan to be carried out if the actual individual took part in organizing it. As said by Dr. Perla, unmet social needs represent a disastrously overlooked or ignored underpinning of poor health, disability, and even death. Doctors use the term comorbidity to describe the simultaneous presence of two or more chronic illnesses or conditions in a patient. They readily include high blood pressure, diabetes, obesity, depression, and others. It is high time to include in this definition things such as inability to get enough food, not being able to refrigerate insulin because the electricity got shut off, not having a safe or secure housing, or things alike, because this also plays a part in returning to health. Benefits of including social needs in a care plan is the care plan would be more patient-centered. This also empowers the patient while they develop the plan for their own health. Patient is more likely to participate and be more involved in their plan of care. The plan will be more likely to address the majority of barriers to good health. Resources can also be tailored more effectively to accommodate this patient so they don't return with the same problem. And most of all, the practice will aid practitioners in better understanding need prevalence in the primary care clinic. How can we incorporate this change? We first have to deal with the rapport and trust between the client and the practitioner. More time must be allowed for the patient to express their needs, their problems, and their goals of how they want to accomplish these problems and goals. A patient needs time to build this rapport and trust with the practitioner. More meaningful time is needed. Practitioners also need to incorporate social needs in their technology platforms. As supported by Dr. Perla, we don't have enough broad data on patients' social needs because we don't routinely collect it. We must build social needs questions and workflows into our electronic health and medical technology systems. Developing a small set of standard social needs questions would make possible meaningful comparisons across different health systems, surface areas, and geographies. The second thing is empowerment of the patient. Goals should be developed by the patient. Assessment of what the patient knows or understands about the disorder should be also addressed. Encouraging them to express their feelings of the disorder and share their cultural beliefs regarding the illness will also help in empowering them. As said by Mr. Winston, trauma in the terms of illness robs the victim of a sense of power and control. The guiding principle of recovery must therefore restore power and control to the survivor. As said by Glacier, there is a need to transform the approach to care provision so that the services are configured to prioritize the patient needs rather than those of the healthcare system. The third thing is collaboration. First off, biases about certain classes of patients should be eliminated completely, and an open mind should be present at all times when assessing or reevaluating a patient by a practitioner. Educating the patient thoroughly about the disorder and informing them of why every intervention is necessary and the significance of the results can also help with the patient. Setting limits and encouraging positive behavior needs to be a part of the treatment. Just to throw a little facts out there about the importance of social needs assessment. Unmet social needs are associated with nearly twice the rate of depression, 60% higher prevalence of diabetes, more than 50% higher prevalence of high cholesterol and elevated hemoglobin A1C, more than double the rate of emergency department visits, and more than double the rate of no-shows in clinic appointments. A recent study conducted by researchers at Massachusetts General Hospital in conjunction with the company HealthLeads affirmed that social comorbidities are an inescapable reality of patients' lives. Likewise, they should be an inescapable reality of the business of healthcare. Today, it's widely recognized that just 10% of health outcomes are attributed to medical care, while 70% are tied to social and environmental factors. In closing of my presentation on social needs incorporation, all in all, mental health is all really about social health. You cannot help someone to get to social health without knowing and assessing their social needs.